So first thing that I look at, and we talked about this a little bit earlier, you brought it up about posture, right?
Yes.
I am, the second somebody walks in the door, I'm looking at where are their shoulders? Is one higher than the other? Is one more forward? Are they both super forward, right? Are they hunched, right? Or are they like kind of back, but one seems like shifted, right? What's their arm positioning like? Do they have to hold their arms way out here? Is it way in, right? Like looking at all of those just little minute things that you wouldn't necessarily think about on a daily basis as you walk around in your daily life. But you and I kind of look at that and we're like, okay, you clearly have, this is your dominant shoulder. This causes a lot of issues. And no wonder you're having pain because this shoulder is far forward and this one is normal, right? Yeah. So those little cues that we kind of look to, that's the first thing I'm doing. Usually when I either have somebody in front of me or I get them on the table, we're going to do some range of motion, right? We're going to look at, can you even get your arm overhead without that shoulder shrug? Are you
Correct.
having to compensate? What about coming out to the side? What kind of causes anything behind your back? Can you move that way, right? Without causing pain or significant issues, right? So kind of looking at that range of motion. I might do some strength testing sometimes, but again, that's more my athletic training wheelhouse than it is massage therapy. So if somebody's coming in for massage therapy, I'm going to probably say range of motion is usually good for me to figure out what muscles are tight, overactive, things that I need to work on. And that's what we're going to kind of hit. If I'm doing more of my clinical side, I'm going to get a little bit more in depth with that evaluative stuff, especially with your special testing and, trying to figure out and narrow it down. But yeah, that's kind of my general assessment. And then I'm sure you have your McKenzie method will come out to play.
Yeah, that's where I was going to go first. But I, once again, fully agree. I mean, no matter what, like the very first part is we're taking history always at the beginning and we're listening to you. But while we're listening to you, I will never mention to somebody anything about their posture right away because like I want to see over the course of a 15 to 20 minute history while we're talking, do you basically put yourself into like posture? And I guess now everyone's going to be super aware of it if they watch this before they come in.
I should probably stand up straighter
but you're right. Like definitely like I fully agree. Looking at shoulder position, I don't necessarily get too obsessed with one high versus low. I kind of actually go more from like the side profile and look like is one like rounded in and down versus like that. I actually try to get a little bit more kind of clinical relevancy with that, especially when it comes to like pec muscles, but it's still all important, right? All the same ranges of motion as well too. I actually will typically, if I'm doing a full on and I'm getting baselines before doing the McKenzie assessment. So with McKenzie assessment, we got to get baselines. We got to see what's functionally limited or what sort of things are creating pain and discomfort during, and those serve as our baselines. Then we try a repetitive movement exercise. If it's a shoulder that we could call a derangement, then it's going to have a directional preference. And so the directional preference will become obvious because then if we do 10, 15 reps of a specific exercise and then all of a sudden those baselines improve, then that's the directional preference. It's pretty straightforward. As much as it's glorified, it's basic at the end of the day.
Yep.
And I usually find, much like you, that just with the shoulder joint, and we can't really talk about pectoralis without talking about the shoulder, but there are 6 degrees of mobility at the shoulder. It is basically one of the most flexible joints in the entire body. You could go forward and backwards, you go side and across, and you can rotate. There's not very many joints that are a ball and socket and give you all 6 degrees of planar movements. As an aside, the hip is also one of those that does that, but the hip doesn't have the same amount of flexibility as the shoulder does. But because it doesn't have the same flexibility, it actually has better stability. So it's one of those things. Flexibility and stability are inversely proportional. You don't get to have both at the same time, right?
As much as we would love it some days.
Yes, exactly. So I'll actually find in the assessment that honestly, if I do like the 6 ranges of motion, so flexion, extension, abduction, adduction, external rotation, internal rotation behind the back, usually that's enough to at least have 2 or 3 to jump out as a problem if we have a pec muscle. Much like you, if I want a little bit more data, if I'm still not quite certain, then I'll put the patient down on the table. I'll isolate pec minor with a functional muscle test. I'll isolate pec major with a functional muscle test. Maybe like test the strength of the serratus muscle and just maybe grab 2 or 3 muscle tests to be certain that if we do our McKenzie exercise, then we could go back and things should neurologically be turning back on if we're moving the shoulder the right way to offload that pec.